medications, they weren't developed for weight loss originally. Wegovy and Ozempic were developed for the control of diabetes. Life-changing. We're getting results for weight loss with these medications that parallels what we're seeing with bariatric surgeries. People who have obesity, it's an addiction, it's a chronic condition, and this medication is transformative for them. But what scientists notice using these drugs is great, but it can also...
Dr. Greg Grosicki.
Kristen, so happy to be here.
I'm so pumped for this conversation. You have an extensive research background, and you actually got your master's in data science. Talk a little bit about, what motivated your PhD, and then just your desire to kind of go back and get your master's in data science. Like, those are pretty big decisions, like when you were like, okay, what am I actually going to focus my dissertation on in my research?
Well, I've been very blessed to have a lot of opportunities to study from some really fantastic scholars and mentors. And so obviously that's been a privilege. PhD was at the Human Performance Laboratory at Ball State, which is founded by legendary David Costal, who in the field of exercise physiology
just
doesn't get much higher than Costal, right? At lunch, to have Costal come over and grab us and pull him downstairs to go swim with him because he was working on breaking the 80-year-old freestyle swimming record for masters, and getting to grow up and advance my scientific toolkit in that type of environment. It's incredible. And it's simple things like he was working on a presentation. Grosicki, come over here. Here's a bunch of articles, but I don't know how to get my figures into this PowerPoint. It's like, oh, Doc, well, we can actually find the article and do that, right? But it's just an incredible experience, and mostly studied muscle physiology, particularly in astronauts and elite athletes, and then the other piece of the spectrum, older adults. So how can we learn from people going to space, some of the highest performers in the world, to make an older adult muscle like that of a 20 or 30-year-old? And there's a ton of lessons that can be applied. And I think that kind of set the foundation for how we can ask questions at Whoop, right? How do we make people who are 50, 60, 70, 80 years old function and have the same type of capacity that someone who is 20 or 30 and an elite athlete trying to be? Then for my postdoc, was brought to Boston by Roger Fielding, and got to study with him, particularly looking at sarcopenia and the microbiome. Then from there, had a professor position in Georgia, where studied more cardiovascular health, and got to work alongside Dr. Andrew Flatt, who is an absolute legend in the field of heart rate variability.
I got to meet him at University of Alabama.
Oh, yeah?
Yeah, it was, I think, in 2017, but it was a real highlight, having read all the HRV research, and, he was like the man,
He's rare in that Andrew is one of the most like open and transparent and like kind scientists you'll ever meet. And you could he's the type of guy you just want to go out and like have a beer and a dinner with him, because very sharing. And so really learned a ton about heart rate variability from him. And so I attribute a lot of my success in that field to working with Dr. Flatt.
His research really, kind of in some ways inspired, a lot of our algorithms and kind of how we thought through it. And so he's really just, he's been instrumental.
Now, obviously I'm here, but I think that's kind of the cool thing about like my career from an academic. There were a lot of different avenues I went down, and kind of made me a bit of a like jack of all trades, master of none. But I think at Whoop, that can be kind of advantageous, right? Because we do need to be broad. We know that there's not one particular ticket to having the best possible and healthiest possible life we can, right? It's the being able to understand the vast body of literature and say, okay, like how can we optimize health through things like sleep and activity and other health promoting behaviors that people haven't even really begun to investigate in their novel, which is what we're able to do.
Yeah. All right, let's talk about the study.
Yeah, would love to.
Okay. There's a lot of different entry points, but I think probably the most important is to just set the stage on what is GLP-1. Just give kind of an overview of the class of antagonists, because I think that's important just for people, because there's just so many different names. I think, tirzepatide and semaglutide is kind of how I bucket them. But I think the landscape is getting, there's more and more kind of coming on the market. Like how I thought about it a year ago is different than how I think about it now. So maybe just kind of give us a sense of, all right, where is the research right now?
Yeah.
And just a broad definition of what are these things, and, what are they being used for?
The thing that surprises most people when you talk about GLP-1, particularly medications, right, is they weren't developed for weight loss originally at all, right? These medications were developed for the control of diabetes, and particularly type 2 diabetes. And in case people aren't familiar, that's when people have blood glucose that gets too high. And with type 2, that's often because they're not able to bring glucose into the cell effectively. And so these medications weren't really developed for weight loss, and they do certainly induce profound weight loss, and that's what they're most famous for. But the discovery of GLP-1s, and this is, I think, kind of surprising to most people, dates all the way back to the very beginning of the 20th century. And scientists realized that an intestinal extract actually lowers blood glucose. And that was in an animal model. I believe it was in dogs. But then in the 1920s, scientists found insulin, right? And they're like, oh, well, this is the golden ticket for treating diabetes. We'll use insulin. And insulin is great, but it can also, if you give someone too much insulin, lower blood glucose too much, and that can cause serious consequences and possibly death. And so, yeah, insulin's great for the treatment of diabetes, but there was always kind of in the back of people's minds these GLP-1, or really the early observations that this intestinal extract lowered people's blood glucose. Well, in the 1950s, scientists found that when someone ingests carbohydrates orally, it actually leads to a greater insulin response than if you were to inject it. And while they weren't totally clear on what to make of that observation, what they did realize is that, okay, this at least suggests that something to do with the ingestion, the oral and intake of carbohydrates is leading to something coming from the gastrointestinal tract, probably the intestine, that is increasing insulin. Now, insulin is produced in the pancreas, right? And the pancreas senses glucose levels. And when glucose gets high, the pancreas secretes insulin to bring glucose back down to kind of our resting healthy levels. Now they're observing that there's something going on in the intestine that's leading to more pancreatic insulin production.
And absorption in the intestinal tract.
Particularly, yes, when food is ingested and it goes into the intestinal tract, for whatever reason, leads to a greater insulin response than if it's injected orally, right? And so that really sparked the search for what was called incretins. And incretins were the name of these hormones that were lowering blood glucose through that greater insulin response, but no one really knew what they were, right? It's like, well, there's these incretins and they exist and they're lowering blood glucose, but where are they produced and what are they called and why? And scientists and drug companies knew that if we can find these incretins, then we can have a meaningful impact on, people with metabolic disease and with type 2 diabetes. But they didn't really know where they were. They do a bit more discoveries. And then in the 1970s to 1980s, they start to figure it out. And so going back, we talked about insulin is produced in the pancreas. Well, there's another hormone produced in the pancreas known as glucagon. Insulin and glucagon kind of have these opposing forces, right? When blood glucose is high, the pancreas secretes insulin, and that helps lower blood glucose. Well, when blood glucose is low, if we haven't eaten for a while, a healthy pancreas will secrete glucagon, and that tells the liver to break down its glucose stores, which are known as glycogen, and that helps maintain normal blood glucose levels. We all know we want to maintain our normal blood glucose levels. We know what it feels like when they get too low, and so we knew glucagon comes from the pancreas and does that. Well, what it was realized was that the glucagon gene actually is expressed more than just in the pancreas. And as a matter of fact, it's also expressed in the intestine. And the protein product that comes from that intestinal expression of glucagon isn't the same as conventional glucagon. And that was actually evidence of this glucagon-like peptide, right? And now we're getting into the realization of GLP-1, which stands for glucagon-like peptide 1. And there were two of these incretins, right? One was this glucagon-like peptide, or GLP-1, and the other one was one known as gastric inhibitory peptide, or GIP. And so scientists found these. This was in the 1970s, 1980s, and they were off to the races. It's like, okay, we found these hormones that are increasing insulin and can have a meaningful impact on these people's with diabetes on their lives. The easiest solution to this would be simple, right? We give someone GLP-1, right? Their blood glucose goes down. Well, not so easy, unfortunately, because GLP-1 has a very short half-life, about 2 minutes. And so, we could give someone GLP-1, but in 2 minutes, most of it's going to be gone. It's not going to have much of a physiological effect, right? The reason why that is because there's another enzyme in the body called DPP4, right? And DPP4 degrades GLP-1. So pharmaceutical companies say, okay, let's make a drug that targets this DPP4 mediated degradation of GLP-1. And those drugs went into market. They're known as gliptins, and they do elevate GLP-1. They were approved by the FDA for managing blood glucose, and they were effective. They had efficacy for people with diabetes, so that was great. But when we look at these, DPP4 mediated degradation of GLP-1s and blocking those DPP4s, we still see that GLP-1's only elevated for maybe 1 to 2 hours after someone takes one of these DPP4 inhibitors, right? And so, really, the drug discovery process has been all about iterating on how can we make GLP-1 go up, stay elevated for longer periods of time, and how can we increase its quantity, right? These DPP4 inhibitors, maybe it's up for 2 hours after, okay? And a lot of people, when you bring up GLP-1, they'll talk about the Gila monster, right? And that's actually where uh, the first GLP-1 that was given to humans really came from, actually. It was a scientist studying the Gila monster, and what they noticed was in the saliva of the Gila monster, they had this longer lasting GLP-1. And so that was marketed and sold and approved by the FDA. I believe it was in 2005, and exenatide, and it's a medication that's used to treat type 2 diabetes, and that was GLP-1. And that stays elevated for longer in people's blood. And so it's having more of this therapeutic effect, right? And the pharmaceutical companies continue to iterate off of that. And I think the next big discovery was really liraglutide, which was approved for diabetes in 2010, but there was and that elevated GLP-1s even more. We're talking 100-fold maybe. But what scientists noticed, and a lot of this goes back to animal models, when they gave people liraglutide, is it had this anorexic effect that they became less hungry. And then when they even started giving it to people, they realized they could get kind of nauseous. They weren't eating as much. And they're like, whoa, people are losing weight from this stuff. And so next thing you know, 2014, the FDA approves liraglutide for weight loss. People are taking it for a year, 10% reduction in body weight. This is pretty good. All right. Now the pharmaceutical companies are really off to the races. 2017, we have Novo Nordisk rolling out with semaglutide, and that's what people more commonly know, right? Wegovy, which is the one for weight loss, and Ozempic, which is the one for diabetes. They're really the same thing. Now, this is elevating GLP-1s thousands.
Mechanistically, there's really no major difference
No
between the
difference. The
2, yeah.
difference is it's lasting longer in
Right.
people, right? People are injecting it, and it's having effects for a week after they inject it. So it's really the half-life is just so much longer.
Yeah.
Slowing gastric motility, they're introducing satiety, they're improving insulin sensitivity, they're having a whole host of other effects that we're
Yeah.
only really beginning to discover, right? The discoveries have just gone on from there. And every year, it seems like these GLP-1s are being approved for something new, right? So with diabetes and then weight loss,
Alzheimer's,
all
neurodegenerative disease is
and
on
right.
the horizon.
Oh, yeah.
Yeah.
Oh, yeah. In 2021 and 2022, we have weight loss, right? And then cardiovascular disease last year and sleep apnea. And like you're saying, now recent things like possibly Alzheimer's is coming out. Another really cool study just published by the folks at Weight Watchers showed people who are taking GLP-1, it helped them with alcohol addiction and cessation of alcohol. So it's interacting with the brain and dopamine signaling benefits.
Cravings,
Yeah,
just
cravings. Yeah.
generally, right?
Yep, yep, and so that's kind of you asked a short
Yeah.
question, I give you a long. But I do think when people think about GLP-1s, they, "Oh, it's very new and very scary," and it kinda is in a way, but also, people were taking these things and trying to elevate them back in 1990s, and we've known about them since 1900.
So when we look at diabetes in America, type 2 diabetes, 1 out of every 10 Americans have type 2 diabetes, which is kinda wild. Do we know what percentage of Americans who have diabetes are on one of these GLP-1?
GLP-1s. I'm not sure about that. I do know the GLP-1 use is growing like crazy as well, right? A study published by the KFF polls, I think, showed that 1 in 8 US adults have taken a GLP-1 at some point, and in adults who have been told by a doctor that they have overweight or obesity, it goes up to 20%. And if you consider these drugs are extremely hard to get, very expensive.
We
Yeah.
should talk about that for just a second because
Yeah.
it's really interesting. It's like $1,000 a month,
$1,000 a
and when
month.
they look at the data on why people go off these drugs, it's not because of the side effects, which I wanna talk about. It's just it's because of the cost. That's not what is deterring people from continuing these drugs.
Yeah, no, for sure. Cost is, I think, definitely a huge reason people are discontinuing them. And if you look at the discontinuation numbers, they're quite high. I just published a study in diabetes, obesity, and metabolism that actually looked at that. And of people who are going on GLP-1 drugs purely for weight loss, and this is real world observational studies. So we're not talking about when they're getting the drugs from, one of the pharmaceutical companies. Over half of them are stopping before a year, and that's not how these drugs are intended to be used. So that's a problem, right? We have this mismatch between how are people actually using these drugs and how are they intended.
Maybe just outline, like, what people would expect if they were to go on Ozempic, and maybe who would benefit from we kind of just you just gave a laundry list of the different effects or impact of these drugs on cardiovascular health and potentially, brain health and, metabolic health, obviously well known. For folks who are wondering if they meet the criteria, what would be that criteria, and what would people expect to happen once they go on these drugs?
For managing excess body mass, the criteria are simple. You either have to have a BMI of greater than 30, and then your doctor is able to prescribe it for you. Or if your BMI is and that's classified as someone who has obesity, or if you're in the overweight category with a BMI of between 20 to 27 to 30, and you have one cardiovascular or metabolic risk factor, BMI of 28 and high blood pressure, then you're able to be prescribed these drugs. And when we look at weight loss with the newer medications, so we're talking semaglutide and tirzepatide, which the ones for weight loss would be Wegovy and Zepbound. A year after taking these medications, in the clinical trials, people are losing about 20% of their body weight in 12 months. It's life changing. We're getting results for weight loss with these medications that parallels what we're seeing with bariatric surgery.
I think the addiction piece is really, really interesting to me. Cravings are tough, right? And um, modern society isn't really set up in a way to protect us from any of that. It's just so easy to get food,
Oh, as a
right?
matter of
It's
fact, it
so
facilitates it, right?
it facilitates it, right? And so we're kind of like handicapped. Not to create a lot of excuses, but it's hard. Like I think being a human in this world of abundance, right? And it sounds so counterintuitive and it sounds ridiculous almost when I say it, but I think that's kind of the crisis that we're in, right? Is we have access. I mean, the food industry, that's a whole nother conversation of just how messed up the food industry is and access to all these processed foods, which are contributing to this epidemic. But I think at a foundational level, to have something that can help people with cravings, I think is transformational. Maybe talk a little bit about willpower.
Yeah, no, certainly. And there's a big discussion, I think, in society at large about these GLP-1 medications, right? And you see people, well, how about lifestyle? Like, how about we teach them to sleep better and to eat better and to do
Yeah,
some
no shit.
exercise, right? It's like, well, how many years have we been telling people you need to sleep, eat, and do some exercise, right? And the truth is, it doesn't work. If it would have worked, it's worked already. And that's not to say it can't, but there's certain people, right? And particularly people who have obesity, which is a chronic condition, and it needs to be treated as such, for whom these medications are a life raft. This can literally pull people out of people don't lose weight. They
Just
aren't good at it.
lifelong struggle for
Yeah.
most of these folks,
Yeah, it's
right?
chronic, and this medication is transformative for them. And just like you said, because of it's an addiction. It's a chronic condition.
Talk about the folks who are using it. I see a lot of Hollywood celebrities who are, all of a sudden really skinny. Um, talk about what's happening there.
Yeah, there does seem to be a lot of off-label use of it, right? We see it in the papers. It hasn't been approved for that. And so endorsing something like that would be extremely challenging. That being said, there's been a lot of research on GLP-1s over the past 20 years and not a lot of negative findings so far. So it does beg the question of where the future of this space is going to go. And when you look at the upcoming studies from these big pharmaceutical companies, they're doing some very exciting things. From right now, people are having to inject themselves weekly, right? Can we extend that to a month? Can we take a pill, right? Another big obstacle. People don't like injecting themselves, and who's to blame them, right? And so to think about where this may go in the future, it's exciting and scary, and
Yeah.
it's just, yeah.
In the functional medicine space, this is being added to the stack of modalities essentially, which is kind of insane to me, but like microdosing,
Yeah.
basically Ozempic. What are your thoughts on that? It's my doctor actually brought it up with me, like, is this something you want to try? I'm like, I don't think so, but
Yeah.
but I think in terms of longevity and everything, we think about like neurodegenerative disease, if you have if you're predisposed to that, or cardiovascular risk, like, is there space for a healthy adult who is doing all the things to be microdosing?
We certainly don't know, but I certainly wouldn't dismiss the possibility, right? If I'm not mistaken, I believe I saw something the other day that what needs to be next checked out is using this for athletes as a doping protocol, right? We think about
Yeah,
athletes where weight is a big piece of
that's
the
where I was
puzzle.
going. I
I
mean, I
mean,
think wrestling and
cyclists,
cycling and, I mean, boxing.
do you say that people can't use these types of things? And then if so, how are you detecting it? This poses a lot of problems, and
Yeah,
it is an exciting time, I think, in
yeah.
the human performance space. But yeah, there's a lot of unknowns in that area.
We're investigating the unknowns all the time, right? We're going into our massive data set and being able to ask these interesting questions. Talk about how our research, kind of came to be around this topic, and, just tell us the journey that led to this recent publication.
Yeah. So, as scientists, we're always looking at the literature, we're following trends. And one of the things about me is I'm following trends all over the place, which I sometimes get critiqued for, but other times it leads to things like this, right? But ultimately, I think, the idea for this paper came from one of our team meetings, right? And we were sitting around one day, and I think maybe it just started with a question. And it was me asking Finn, one of the wonderful things about Whoop is we have this behavioral tracker. And so people can log everything under the sun, from an ice bath to taking magnesium to sharing your bed with a dog. And so I thought, well, Finn, are we asking anybody questions about taking weight loss medication? And sure enough, we were. Now, it wasn't specific in the slightest. And this was, a while back now. It wasn't specific, right? It was just, are you taking weight loss medications? Yes or no? And I was like, oh, this is really exciting, right? And I'm talking with Finn, I'm talking with Jane, I'm talking with you, talking with Bill and Chris, everyone on the team. It's like, well, what if we were able to look at the users who have selected that they've taken these medications and then send them just a brief survey, really, a short survey. What medications are you taking? Does it happen to be a GLP-1 medication? And if so, would you be willing to share some of the data from your weight loss journey with that medication, right? Simple things like, did you weigh yourself at 4, 8, and 12 weeks after you started using these medications? Things like that. We sent that survey out, right? I think another one of the cool things about Whoop, right, is like members love helping us. And so we have to be grateful for that,
I
right?
know. We love you so much. Thank you.
No, but seriously,
I
right? They
totally.
respond to the survey, which
They're
really
so
unlocks
good.
our ability to figure these things out, right? And a bunch of them got back to us and said, "Yeah, I am taking these medications, and this is how much weight I've lost on the journey," right? And then so we were able to go back in their data, look at, okay, what day did you start taking these medications? How much weight have you lost? And then the thing with these pharmaceutical companies is they're very good about publishing about how much weight people lost, and did they get diabetes, or did it prevent them from getting diabetes, or did they die? These are all great things and they need to be known, but the pharmaceutical companies aren't in the business of talking about lifestyle, right? They make no money from it. And one of the things about Whoop is we know your heart rate and your heart rate variability and respiratory rate, your body temperature, all these things, but we also know literally, if you're using the device as you should, what you've done
Yeah.
every second of the
Yeah,
day.
how much you're exercising, how much you're sleeping, when you're going to bed, when you're waking up. I mean, the data just are never ending.
Exactly, right? And so we're able to look at these data from these
Anonymously,
people.
of course.
Yeah, yeah, we don't know their names, but thank you to them for 12 weeks, every second of what they've done, how much they've moved, what their heart rate is, and to answer the questions that for a clinical trial would take hundreds of millions of dollars and probably 2 or 3 years. And so that's where, we really got excited. It's like, okay, we have these members who have been using these medications. We know what their biometrics look like. We know what their activity has looked like. And then we were able to leverage, some more data science and statistical techniques to basically take the members who were taking the medications and for every one of them, basically identify their virtual twin in our database, right? The great thing about having so much data is if we have a male who's 5'8" and weighs 235 pounds and has a resting heart rate of 70, and we can say, okay, let's find another one, but this one needs to live over here and didn't take a GLP-1
Yep.
medication.
Match.
And so
Yeah.
for every member who was taking the medication, we were able to basically find their twin who wasn't and set up through this type of technique, not a randomized control trial, but one that's almost as powerful. And that's what ultimately we're able to do with this study.
It's so funny, just as you're talking, I get so excited, I'm like, "I can't believe we get to do this every single day," this type of research. Huge shout out to our members who replied to our questions and, gave us this really valuable data that allowed us to pursue this question, with such rigor. Why don't we talk through the results? What do
Yeah.
we see, and why are they important? How can we make broader recommendations for folks who are considering these drugs?
Yeah, now it's our time to give back to the members, right?
Yeah,
Like, thanks for the
exactly.
data. Now let me
Yeah.
tell you what we found.
Yeah.
And this is where, like, it's like, we were having our meeting the other day and I was like, gonna show you some data. Like, I'm like, hold on, I gotta get some water. It's like we sit on Christmas, right?
I
And
know.
sometimes, like,
We're like,
before
"I
I
need to
push,
get settled."
yeah, I know. It's like before I push the code, I'm like, okay, like Grace is at school,
Yeah.
like I've had lunch, like, okay, let's like see what this looks like,
Yeah.
right? Like it is like it being
This
like
is
8 again
Christmas every
and
day.
coming down the stairs. The first question that we were able to answer from this is what does weight loss look like in the real world with these medications? The pharmaceutical companies are great about publishing what weight loss looks like in this very tightly controlled
Right.
setting. In the real world, it can be very different. And so we looked at self-reported weight loss among our members, right? And what we observed is that in 12 weeks' time, self-reported weight loss was 10% of their original body weight. 10%
How
of
does
the
that compare to clinical trials?
yeah, I mean, you look at the data from semaglutide and tirzepatide, and it's 6, 8, maybe 9%, but truth be told, numerically, the number was higher in our
By a
members.
lot.
Yeah, it is. It really is. And the other thing is that of the members who were taking the medication, 90% of them who provided a weight at 12 weeks lost more than 5% of their body weight, which is clinically meaningful. It means that it improves their likelihood to live longer, healthier lives, right? In 12 weeks. The big clinical trials, this is what we're seeing, the 90%, 5% weight reduction in a year to a year and a half, right? And
Right.
we're seeing that in 12 weeks. And so then, okay, chicken or the egg, like,
So, basically, what the amount of weight that folks are losing in a year in a clinical trial is the same as what Whoop members are losing in 12 weeks, roughly.
yeah,
Yeah.
let's say it this way, right? The amount of folks who are reaching this clinically significant weight loss is the same that we saw
Right.
in 12 weeks,
Right.
right? And there are nuances of how these GLP-1 medications work, which is they promote a lot of weight loss initially, right? In the initial 12, 16, 20 weeks, people lose a lot of weight. But the truth is, and these data are just coming out now, there's data showing what happens if people take these drugs to 3 or 4 years. And
Yeah.
after a year, they stop losing weight. They don't lose any more weight. It takes basically continuing on the drug medication, and we talked about what that's costing
Yep.
for them to just to maintain the
Right.
weight they've lost, right?
Right.
And I think one thing before I forget, right, we should all just be very upfront about is when the FDA approved these medications for weight loss, it approved them in conjunction with physical activity and a reduced calorie diet, right? And we can't beat that drum enough. It approved them with increased physical activity and a reduced calorie diet, and is not just saying just take these medications alone.
The one thing that I think we also should point out, just because I think we always try to be as honest as possible, folks who are on Whoop, there is a kind of a user bias that we should probably talk about. They might be slightly more motivated, right? Might have more resources. Who knows? But maybe just talk through
Yeah,
that.
yeah, that's a good caveat. It's
Yeah.
important to be honest here, right? First, the weight loss was self-reported. There's gonna be a bias there. People are
Mhm.
gonna be more likely to want to share their weight loss if they've lost more weight.
Right.
People who are willing to partner their weight loss journey with Whoop might be more motivated to lose weight, right? It also very well may be that buying Whoop is helping facilitate the FDA's recommendation to increase physical activity and follow a reduced calorie diet, whether that's through our coaching or just looking at your wrist and knowing that someone's watching. And at the end of the day, you have to be held accountable. We don't know. And those are certainly things we need to look at in the future.
When we zoom out, though, and we think about a weight loss journey without considering exercise and sleep in parallel, you're missing a big piece of the puzzle. So there's no surprise that there is some sort of kind of acceleration in weight loss when people are just conscious of their sleep and activity levels. It's a cool, I think, moment for Whoop,
Yeah.
to in a where we have just really been known for elite athletes and, kind of professional athletes really maximizing, and calibrating their lives around these data points. Like, there is no question, and we've been saying this for years and years and years, that, Whoop is really for everyone, right? Anyone who is on any type of journey where they're trying to extend their life, trying to be as healthy as possible, extend their health span. Whoop is just the ultimate partner in that journey, right? Because you're zeroing in on everything that is foundational, right? If you're layering GLP-1 on top of crappy sleep, not enough exercise, not getting into the weight room, like, it's a house of cards. You've got a foundation that has cracks in it, right? And you're layering inefficiency really on top of inefficiency. But when you deal with this foundation and you're proactive about the foundation, I think
Yeah.
the results really show that you can make more gains, right? When you're layering these modalities on top.
Yeah. And I mean, we can't ignore, the starting place where we talked about, do people take these medications and how long do they take them, right? And we said that half people who take them in the real world are likely to stop by a year. And the data are very clear on what happens if you stop taking these medications.
Yeah.
And the pharmaceutical companies have published it. You stop taking these medications, and in a year, people on average have gained 2/3 of the weight they lost back. We don't know for sure, but it seems very logical that the only way to keep that weight off would be through
Exercise,
exercise and
sleep,
health behaviors and sleep, right?
diet.
You can go on these GLP-1 medications and lose that weight, but at the end of the day, the rubber meets the road. You got to have some sort of lifestyle behaviors to support this weight loss long term.
When you look at GLP-1 use and cardiovascular health, you'd say when you zoom out, it improves cardiovascular health. Yet we see clinically significant increases in resting heart rate and decreases in heart rate variability. Kind of talk through the contradictions there and how you interpret that.
It is a bit perplexing, right? And all these pharmaceutical companies, when they have these drugs, they have to do these cardiovascular outcome trials to look what happens. And demonstrably, major adverse cardiovascular events when you take these drugs go down. And for that reason, the FDA has approved them for reducing cardiovascular disease risk. So that needs to be said. That being said, it's perplexing because when you take these medications, and in our particular findings, right, we saw that on average in 12 weeks, resting heart rate went up 3 beats per minute, and heart rate variability went down 6 meters per second. And that's in the people we're looking at a significant change, right? Resting or heart rate variability is down 10, 15, 20% in these individuals, and resting heart rate is up 3 beats per minute. That's a lot, right?
It
And so,
sticks.
right. And so how do you marry those findings? It's like, yeah, it does seem good overall, but if I'm taking these medications with the goal of improving long-term health and living as long as I want, I'm probably trying to find a way to attenuate or
And
prevent
offset.
that. Yeah,
Mhm.
that's one of the things we were able to look at.
Right, and we saw that folks who are exercising talk through that result, so the
Yeah.
30 minutes of exercise and
Yeah.
people who were exercising, the impact on their cardiovascular how that changed
Yeah.
their
Yeah.
cardiovascular parameters.
So I think one of the things that we were able to look at, going back to the novelty of Whoop and having this data, is we were able to look at what happens when you take these drugs on lifestyle behaviors. And as far as to the extent of my knowledge, no one has ever done that, particularly with physical activity, right? People have looked at it with drinking alcohol, but we were the first, to my knowledge, to say, okay, when you take these medications, do people change their behaviors in regards to physical activity, right? And we showed data suggesting that indeed people who take these medications relative to those who don't, because we were able to use this particular type of analysis, seem to increase the amount of physical activity they were doing at week 12 versus at baseline. And perhaps that's not super shocking, but we were the first ones to show it. And it's great to have those data, right? And it could be for a lot of reasons. People have lost weight and now it's more comfortable. for them to exercise.
Their energy levels increase, they're
Energy
sleeping
levels are
better
higher. They're more
potentially.
motivated because they see the weight coming off, right? Or it could have to do with the way these medications are affecting dopamine in the body, right? We don't know, but we were able to show that. And so that's really interesting. And we know, right, from a vast body of literature in exercise physiology that one of the benefits of being physically active is that it reduces resting heart rate. And that's a beneficial thing. And so we hypothesized going in, but had no idea whether or not we would see it. Do those who do more physical activity when they take these medications maybe not see those changes in heart rate that we see in the regular population? And that's where it gets really exciting. We showed trends suggesting that that's probably the case, that people who take these medications and exercise more, their heart rate doesn't go up as much when they're taking these medications. And that seems like it would happen. We are the first to provide definitive evidence of that. And that is really freaking cool,
Yeah,
right? I
totally.
mean, it doesn't get cooler. Like often when you go into a study like this, like your hypotheses don't pan out. They fully did, like just as we would expect. And that's awesome.
Yeah, I love it. Research is hard. A lot of times we go in and we just, you just don't see anything, or what you expect to find isn't true, which is an insight in of itself. To be able to come away with this analysis and see the data that we saw was, I think, really really special and
Yeah.
such a great moment.
And we do sometimes learn more when we don't see what we
Yeah,
want,
totally.
right?
Yeah.
But when it does, it's like, wow, like you said,
Yeah.
like
Yeah.
this is incredible. Like, and it's super cool. And I think it's super impactful for someone who's taking a GLP-1 medication. And really what it's doing is just supporting the recommendation, right? It's
Exactly.
been recommended that when you take these medications, you increase physical activity levels. And we're the first to provide evidence that that is a solid recommendation
Yeah.
for cardiovascular health.
As someone who has, extensive expertise in sarcopenia and understands what's happening, a very mechanistic level, what would be your recommendation for folks who are on these drugs and, maintaining quality muscle tissue? Like, just maybe walk through that.
That's definitely where this research needs to go next.
Yeah,
And
that's it totally.
just this morning, I was talking to my old postdoc advisor, Roger Fielding, who, the Human Nutrition Research Center on Aging, the word sarcopenia it came from there, right? It
Yeah,
means poverty of flesh. And it came from the Human Nutrition Research Center on Aging downtown. We were talking about GLP-1 and his excitement for the research and all of his colleagues talking about sarcopenia and GLP-1s. And the reason why is very important. When people take these medications, we see that they're losing a lot of weight. 20% of their total weight is being lost in a year. But we see that almost half of that weight can come from muscle. And so the muscle loss with a year of these GLP-1 medications is similar to that we see with 10 years of human aging. Take these medications, you're losing a lot of weight, right? But that weight's coming from fat and it's also coming from muscle. And that proportion varies how much of it's coming from muscle. And to be fully transparent, the implications of that for strength and performance and health span are not
we don't
yet
know.
clear,
Yeah.
but it still seems concerning, particularly if we think about the population who's taking these GLP-1 medications. Most of them are 40, 50, 60 years of age, which is right at the period where muscle loss is about to begin to accelerate. And so it seems as though throwing additional fuel on that fire is not something we would want to do.
If you were to have to recommend, so if someone's really limited time and they're choosing between doing cardiovascular work or musculoskeletal work and they're taking GLP-1, what would you recommend they spend the most time doing?
I'm going to cheat on that question and say both. I'm going to say program that has them doing some sort of high intensity exercise. Resistance
To
training
try
would
to
be
attenuate the
ideal.
effects of resting heart rate and
Yeah, but do resistance training, but then just take less rest between sets, right? Do something high intense.
circuit training,
Circuit
yeah,
training,
yeah,
exactly.
which
Or
is
lift heavy things.
characterized by, like, 45-second on, 15-second off, just alternating muscle groups and adding some cardio. I did a circuit this morning, actually. I did.
There you go. Of course you did.
But I think, working if you have the resources, getting a trainer alongside this journey, using Whoop to kind of, meet your strain targets and, calculate your musculoskeletal load. I mean, these things are all, just inside our app, ready for you to use as a resource to accompany you on whatever health journey you have, frankly.
100%.
Last question. So when you see the future of research at Whoop, both kind of immediate and long term, without giving away any of our secrets, what gets you most excited?
This paper really um, cross-functional paper and effort sets the table for the future of research at Whoop, right? Which is to apply our learnings from some of the fittest human beings on earth to make people live or help them to live longer and healthier lives. And how can we apply what we've learned from a study like this to, to other conditions, right? Cardiometabolic disease, mental health. There's so many different ways that we could go with this, and using Whoop to unlock those secrets, I think, would be the best way to do it.
Amazing. Well, Dr. Grosicki, thank you so much for your time today. I'm so grateful I get to work with you every day and learn from you. And I know our members are going to really love this conversation, the insights that you provided today.
Thank
So,
you, Kristen. It was a
yeah.
pleasure.